Hello and welcome to Workers' Comp Unwrapped, the podcast that simplifies workers' compensation for physicians. So, let's get started. Welcome to Season 3, Episode 19 of Workers' Comp Unwrapped with Anique, your host, and Angela, our guest who has 15 years of experience in the industry. Today, we are talking about proposed utilization review amendments. Preparing for 2025 changes. Prepare for proposed UR changes by understanding compliance and approval strategy. So here we are again. Every year, it seems like California tries to fix workers' comp by adding another layer of rules.
It's the regulatory perpetual motion machine.
It really is. And this time we're diving into a new package of proposals from the DWC that's all about utilization review, or UR.
And I joke about it, but these proposed amendments they're better than espresso for anyone in this industry.
I love that.
I mean, they're crucial. This is the machinery that decides if care gets approved.
Right. And the most important word for everyone listening right now is proposed. This is not law.
No, not yet. The DWC has been at this since 2024, and then the Office of Administrative Law, the OAL, they kicked the package back in 2025.
So they basically said, nope, not clear enough, try again.
Exactly. They wanted tighter language. But the direction is crystal clear.
Which is?
Tighter timelines, much clearer documentation, modernizing the forms, and, just creating a more consistent guideline-driven framework for everything.
So the goal is maybe a January 1, 2026 implementation.
That seems to be the target. Which means if you're listening now, you're getting a huge head start.
Yeah, if you wait until it's final, you're already 6 months behind. You've got to start thinking about this stuff now.
Being proactive on this is going to save you so many headaches down the line.
Okay, so let's get into it. What's actually changing? I mean, what are the concrete proposals that are going to affect day-to-day operations?
I think the biggest one, the most meaningful change, tackles incomplete requests for authorization. RFAs.
The RFA black hole, where requests go to disappear.
Right. So right now, if an RFA is incomplete, a claims administrator can just sort of sit on it. The proposal mandates a 5 business day window.
5 business days to do what exactly?
They have 2 choices. 1, they accept it as complete and the normal UR clock starts ticking. Or 2, they have to mark it not complete, send it back, and this is the key part, give specific, detailed reasons why it's incomplete.
That is massive.
It is.
No more vague, incomplete excuses that show up 3 weeks later.
Exactly. It stops that passive denial game. It basically tells the claims administrator, you need to staff your intake properly or you're going to be in trouble.
But couldn't they just weaponize that? Just flag everything as incomplete to buy a few more days?
They could try, but the rule requires specificity. They can't just say missing docs. They have to say, you are missing the physical therapy progress note from May 15th. That detail is what should prevent them from abusing it.
Okay, that makes sense. So that's the input. What about the output, the denial letters themselves?
Yeah, they're trying to fix those too. The goal is to get rid of those, old generic copy-paste paragraphs we've all seen.
The ones that just cite a regulation number and nothing else.
That's it. The new rule would force them to make solid references to the MTUS, the medical treatment utilization schedule, or to another specific evidence-based guideline if MTUS is silent.
So the denial has to be traceable to a specific clinical rule.
Precisely.
Now, what about the person making the denial? There's a lot of talk about specialty-appropriate reviewers.
Right, and to be clear, this isn't technically a new law. The law has always said the reviewing doc should be competent in that clinical area.
A pediatrician shouldn't be denying a complex spine surgery, basically.
Exactly. But the DWC is reinforcing it by updating the forms. They're adding a spot where the reviewer's specialty has to be clearly documented.
So it creates a clear paper trail for an appeal.
A very clear trail.
Yeah.
And it reiterates that, a nurse or a non-physician can do an initial screen, but they cannot, under any circumstances, modify or deny treatment. Only a qualified physician can do that.
Okay, moving from accountability to maybe just moving into this century, electronic RFAs.
Finally, I am ready to say goodbye to my fax machine forever.
So the rules will formally allow RFAs through EDI.
Yes, electronic data interchange. But there's a catch.
There's always a catch.
Both sides have to agree to it, which, can be a hurdle. Getting everyone's tech to talk to each other is where these things can stall out, but at least the door's officially open.
Speaking of paperwork, what's this about the PR1 form?
Oh, this is a good one. They're making the PR1, the initial treating physician report, optional.
Why was that form such a headache?
Because it was often redundant. A doctor would write a beautiful, comprehensive narrative report with all the clinical details, but then get flagged as non-compliant because they didn't also fill out this specific separate form.
So now they can just submit a PR2 or a narrative report.
Yes, as long as that narrative includes the same declaration under penalty of perjury. It's about getting rid of duplicative paperwork while keeping the legal statement intact.
Okay, and I see 2 more quick cleanup items. Something about the 30-day post-injury exemption.
Yeah, that's just a small but important administrative fix. If treatment is approved under that initial 30-day window where UR isn't required, the approval has to be clearly labeled as a 30-day exemption.
For tracking purposes later on.
Exactly. It prevents confusion down the road.
And the last one is about retrospective UR.
They're clarifying the triggers for it. Basically, they're trying to stop claims administrators from using retrospective reviewing care after it's already been provided as a casual tool to deny payment. It should only be used in very specific situations.
Okay, so before we go on, we have to clear the air about a couple of things people might be confused about. Let's start with the big one, SB 636.
Yes, we absolutely should. That veto caused so much confusion.
So this was the bill that would have required all UR docs to have a California medical license, right? And it would have stopped repeated reviews for care that was already approved.
It was the dream bill for providers. Stop the endless free reviews. But it was vetoed in 2024. It is not law. It is not part of these proposed amendments.
And what does that veto signal to you?
It signals that the governor and the legislature are hesitant to change the fundamental structure of who can perform UR. The DWC, with these proposals, is fixing the process, not the personnel.
Got it. And then there was SB 1127. That one actually passed.
It did pass, but it's often confused with UR reform. SB 1127 didn't actually change the UR process itself.
So what did it do?
It shortened the investigation timelines for certain presumptive injury claims, and it really jacked up the penalties for unreasonable denials. So it's related, but it's separate from the specific RFA and denial letter changes we're talking about today.
Okay, so that brings up the big question.
Yeah.
Why? Why is the DWC going through all this trouble? What are they really trying to fix here?
At the end of the day, I think it comes down to trust. The system is just plagued with complaints.
Like what?
Timing games, which the 5-day RFA rule is meant to fix. Opaque denials, which the new letter requirements address. And specialty mismatches, which just makes injured workers feel like the review wasn't legitimate.
So it's about fixing the procedural breakdowns to restore some faith in the medical decisions.
Precisely. They're responding to years of feedback and court cases that were won not because the medical decision was wrong, but because the claims administrator messed up the procedure.
And when you look at the actual data from independent medical review, from IMR, the decisions themselves are pretty consistent.
They're incredibly consistent. UR denials are upheld something like 9 out of 10 times. The problem isn't the final clinical decision in most cases, it's the messy, frustrating, and often unfair-seeming process of getting there.
So if these changes make the denials cleaner, what does that mean for IMR? Are providers going to start winning more appeals?
You know, it's funny, you'd think so, but probably not. I don't think we'll see the overturn rate skyrocket.
Why not?
Because the underlying criteria for IMR aren't changing.
Right, it's still all based on MTUS and those evidence-based guidelines.
That's the immovable object. The rules for what is or isn't medically necessary are staying the same. What might happen, though, is that we see fewer IMR filings overall.
Because there are fewer sloppy procedural denials to appeal in the first place.
That's the hope. Less chaos in the system means less to dispute. So, don't expect this to be some kind of magic bullet for getting more treatment approved. The bar for medical necessity isn't moving.
Okay, this is the most important part for everyone listening. The rules aren't final, but what should providers start doing right now to get ready?
Number one, and this will never change, is strengthen your clinical documentation.
Be more specific.
You have to connect the patient's symptoms directly to their functional impairment. Not just patient has back pain. It has to be patient's back pain prevents them from lifting more than 10 pounds, which impacts their job as a warehouse worker.
And then connect that functional impairment to the treatment you're requesting.
Exactly. And you have to explicitly reference the MTUS guideline you're following. Use measurable notes. If a guideline requires improvement in gait, your note needs to quantify that improvement.
And with that 5-day rule for RFAs coming, that first submission has to be perfect.
It has to be meticulous. The days of sending in a half-finished RFA are over. You will get it kicked back almost immediately. Your front-end workflow has to be airtight.
And on the tech side, it sounds like it's time to get serious about electronic submissions.
Oh, absolutely. Stop fighting it. EDI is the future. Start building those clean digital workflows now while everyone else is still trying to fix their fax machine.
What about training?
Mission critical. Invest in targeted training for your clinicians on the MTUS requirements. So many preventable denials happen just because the provider's note didn't use the magic words from the guideline.
And get ready to say goodbye to the PR1.
Yep. Adjust your workflows now. Make sure your PR2s and narrative reports are fully compliant so you're not scrambling when the PR1 officially becomes optional.
Okay, let's pivot to the money side of things. For the billing teams, the Lien specialists listening, what does this mean for them?
It means we have to face the post-SB 863 reality, which is that nothing in these UR amendments changes one fundamental fact. If UR denies treatment and IMR upholds that denial, it almost never converts into a viable lien.
The leverage is gone.
It's gone. That door is pretty much closed.
So the financial strategy has to be prevention, not rescue.
Every single time, it's all about clean claims on the front end. Get the documentation right, align it with the guidelines, and respond to information requests instantly. The lien process is not going to save your AR from a sloppy RFA on the back end.
So to wrap this all up, these changes aren't a total earthquake, but they seem to bring some much-needed clarity and maybe rigor to the system.
I think that's right. They're pushing UR to be faster, way more transparent, and more consistent for everybody. That push for transparency is really the core of this whole thing.
And of course, we have to remind everyone listening, this isn't official until the OAL gives the final sign-off, so you have to stay tuned.
Definitely. And before we go, here's something to think about. If these rules force claims administrators to staff up their intake desks to meet that 5-day deadline, what kind of hiring frenzy might we see across the industry before the rule even becomes law?
That's a great question. Join us next time for our deep dives into fee schedule adjustments and how those may affect your accounts receivable strategy heading into 2025.
Stay compliant, stay caffeinated.
Stay compliant, stay caffeinated. Thanks for listening to Workers' Comp Unwrapped. If you found value in today's episode, subscribe and share with fellow doctors. Stay informed and keep making a difference in your patient's care.